How would we treat newly diagnosed atrial fibrillation? So I love this scheme so much. It is from AMBOSS. So first we check for rapid ventricular response. If this person has an heart rate more than 100, if they do, you check for presence of hemodynamic instability, for example, low blood pressure, acute cardiac ischemia, acute heart failure, altered mental status. If the person has it, then you consider them as unstable and check for pulse, no pulse code, pulse present, emergent, synchronized, cardioversion, and etc. And if this person is stable, then you gotta find out how long this episode is lasting. If it lasts less than 48 hours, you go for either rate or rhythm control. If it's more than 48 hours, rate control. Okay, next. What if this person has normal ventricular response, which is essentially a heart rate normal, less than 100, then you gotta choose between rate versus rhythm control, which really depends on duration of symptoms and individual comorbidities. So if here are 3 examples. So the first one, duration is more than 48 hours, long-standing persistent AFib, asymptomatic, high risk of thromboembolism, you go for rate control, and the target of resting HR will be less than 110 for asymptomatic patients with normal left ventricular ejection fraction and lower than 80 for asymptomatic with lenient rate. The first line will be beta blockers or calcium channel blockers, and you gotta think about the anticoagulation, and you tell me how you would do this. So the second example is AFib with pre-excitation, for example, Wolff-Parkinson-White syndrome, new onset AFib, pregnancy, young patient, AFib with reversible trigger. For example, it can be thyrotoxicosis, and you should really think about it if you have a young patient with AFib. Then you can choose rhythm control and do that. And if the person is undergoing cardiac surgery for other reasons, for example, mitral stenosis, or has concurrent heart failure with reduced left ventricular ejection fraction, or patient preference, yes, we do that too. Then you can go with rhythm control via interventional cardioversion, which is catheter ablation, for example. And that's it.